So I'm here in Chicago for ASCO 2014. It's been a very, very exciting year for oncology in general, but in particular in the domain of renal cell carcinoma. Really honored today to have my colleague here, Dr. Sonpavde, who's an associate professor at the University of Alabama. Guru, thanks so much for joining me.
Thank you for inviting me.
Absolutely. So, big year for renal cell carcinoma. Can you maybe give us a sense of what excites you the most about what you've seen at some of the sessions this year?
Well, obviously, I think the major story emerging is immunotherapy, which includes drugs that take the brakes off the immune system and the immune response eradicating cancer, specifically drugs like nivolumab that inhibits a target called PD-1 on lymphocytes and enhances the immune response against the malignancy. Also, the combination of nivolumab and ipilimumab, which is a different inhibitor of a different checkpoint on T cells, so it takes the brakes off the T cell immune response too. So the combination looks very robust.
I totally agree. Now, in terms of nivolumab actually getting to patients, can you give us a sense of what sort of clinical development that drug is undergoing right now?
With nivolumab?
Yep.
So nivolumab is being looked at as a single agent as well as in combination with other agents like the ipilimumab I just mentioned, as well as a trial that has looked at it in combination with anti-angiogenic agents like pazopanib and sunitinib. It also is being looked at as a single agent in a randomized trial right now for kidney cancer, which you might know, in the late line setting, comparing it with Afinitor or everolimus in patients who have relapsed following other anti-angiogenic agents.
And my understanding is that trial has completed accrual now. We're still waiting for the data.
Yes.
I just wanted to ask you, let's say the data for nivolumab, as they're looking for in this phase 3 trial, does show that it improves survival above and beyond Afinitor. How are you going to sequence it? Would it come right after your first line therapy? I think the trial permits up to 3 lines of therapy for entry. Would you use it in third line, fourth line? What are your thoughts there?
My thoughts are that I would use it second line following a VEGF inhibitor like sunitinib or pazopanib, given that we know that second line treatment at the moment with either axitinib or everolimus has very modest outcomes. The median time to progression is around the 4 to 5 month range. So I personally would say that if the nivolumab shows an extension in outcomes compared to everolimus, I would go to nivolumab as my next option following a VEGF inhibitor.
Gotcha. And is there any chance that we might be seeing nivolumab as the first-line treatment for patients with metastatic disease?
I think there is a chance. I think the trial designs are being discussed, and I know that there are some plans afoot to look at the combination of nivolumab and ipilimumab. That's both the drugs